So I'm Dr. Sean Lordan. I own Concierge Physical Therapy here in town.
And where do I get this in with that stuff?
And I'm here to do a talk today on balance, in fall reaction. Okay, so in our seniors, falls are the leading cause of death, right? And to me, I see that as a preventable cause of death. So, a little bit about me. So, I own Concierge. We have 2 locations in Sutton and in Shrewsbury. I'm a published author, and I'm board certified in orthopedics and sports medicine. So I've worked in almost every setting of physical therapy. I've worked in hospitals. I've worked in home care. So I've done a lot, and I've seen a lot over my years. And I enjoy working, I enjoy working in the community, and especially working with, older adults. So here's a little bit about that today. So one of the common, questions that I get is what is balance? What exactly is balance, and can I improve my balance, right? So one of the keys, one of the first things when I start a new plan of care with a patient is we talk about balance, right? Because you really need to talk about balance before you talk about falls. So balance really, to me, it's got a lot of different things that contribute to it. But the first thing that I talk about is that balance can be improved upon, okay? So balance is a skill, and there's 3 major systems. I'm going to try to keep my voice as loud as I can. There's 3 major systems, 3 major ones that we can affect that will improve your balance. So of the 6 contributing variables that are up there on the screen, I don't know if everybody can read that, the 3 that I focus on in my PT clinic and with my patients are your inner ears, so your vestibular system. Who here has ever had vertigo? Or BPPV, or who here has ever sat up in bed and gotten the spins? Right, so probably about, it's about 50 to 75% over the age of 60 is going to get an episode of BPPV or benign positional vertigo, okay? That's also something we treat at the PT clinic, and it's an easy fix. We can get into that later. This talk isn't about vertigo, but it's about, how the inner ear systems can affect your balance, okay? So that's number 1, it's just your inner ear, your vestibular system, okay? Number 2 is your sensation, right? So does anybody here have neuropathy, right? Decreased sensation in their feet. Does anybody here wear orthotics? Inserts in their shoes, right? So sensation from the ground, right? So we'll get into that, and that's also a leading preventable cause of change and falls, right? And the last piece is your vision, right? So if you close your eyes, if you're standing and you close your eyes, you're going to be a little bit wobbly, right? Because vision it's always more difficult to walk at night than it is during the day, right? So one of the most common times that you'll have a fall is if you wake up in the middle of the night to go to the bathroom, right? And what's one of the most unforgivable settings in the house? The bathroom, right? Because everything's hard, there's tile floors, there's bathtubs, it's not a great place to have a fall. So what I always suggest, and we'll talk about this later, is preventing a fall from the bed to the bathroom. We want to make sure that it's lit up, right? So little night lights, things like that, okay? So those are the 3 major systems. Other contributing variables, cognition, right? So if somebody's got dementia, Alzheimer's disease, that can affect your balance because you're not making the right decisions, right? And then we really kind of touched on the other ones here, but neuromuscular, somatosensory. What we're doing to treat that is to build muscle and to work on balance. So what are some typical changes with aging, right? So what can we expect? So common changes with aging are what we call in the medical practice, as doctors, is called sarcopenia. Okay, so sarcopenia is age-related muscle degeneration. So if you don't work out or do anything, you lose 1% of your muscle mass every year after the age of 35. Okay, so it's so important to just be consistent about getting up and moving, right? So whether that's a daily walk, whether that's yoga or Tai Chi or whatever it is, whatever suits you, just get up and move for 30 minutes a day, okay? So you're going to have normal effects of aging are decreased strength in your hips, your low back, ankles, knees, right? You're going to have decreased coordination. Your reflex time decreases. Who has noticed that as you've aged, you've had more difficulty driving at night? Okay.
Driving at night.
Or driving in general,
Have more
right? So your reflex time is down, okay? Walking slower, your gait speed changes, your velocity of gait changes, okay? And that also affects how comfortable you are standing on one leg, right? So when you're not comfortable standing on one leg, when you walk normally, you're on one foot almost 50% of the time. So as you start to slow down your gait, you're on 2 feet with an increased stance time is what we call that, right? So you're not balancing when you slow down your gait, okay? When you don't balance, your hips get weaker and your core gets weaker, okay? Great, so it's the leading cause of death from injury, and I would say preventable injury for the most part in our seniors, okay? 1 out of 3 people age 65 or older fall. Less than half of them talk about it, right? There's a huge stigma and fear around talking about falls. You know, and I think there's a variety of reasons for that. And, you know, I always say you just got to tell your doctor. If your doctor's not going to, you know, send you to a skilled nursing facility and, you know, you're not going to live out the rest of your days in a SNF from having one fall. But one fall, I can tell you from experience, always leads to more. So have the conversation. Get in front of it. Among older adults, falls are the leading cause of both fatal and non-fatal injuries, right? So it's the leading cause of death, right, from injury, but it also can cause a lot of comorbidities, right? How about a broken arm? How about a broken ankle, right? What we always, you know, we don't always see, but we commonly see too is in older age is a hip fracture, right? And so sometimes those hip fractures are from falls, but sometimes they're just from inactivity and not working out as a result of potentially having a fall, and then you dial back your activity, you get up one day, and then that hip fractures, right? Because we have comorbidities like osteopenia or osteoporosis that come with age, okay? So just thinking about that regular activity program and talking about falls. It's okay to talk about falls, and you should be talking about falls with your medical providers, right? Physical therapists, primary cares. So these are just some false stats. So it's this is $30 billion in 2014. I mean, with inflation in 2022, I mean that could be upwards of 100 billion. You know, you're talking about 2.4 million non-fatal falls. You know, and about a quarter of them were hospitalized. So, and again, so you have a fall, you're not hospitalized. Have a conversation so you can get the right plan of care. Okay. And so these are 2014 statistics. So an average episode of cost for a plan of care for a fall was almost $20,000, and that's 8 years ago, right? So we're seeing increased costs, especially in our seniors, if they don't have gap plans, Part B, you know, not advantage plans, but like supplement plans. That's a talk for another day. You know, this is from the provider side, but it's really important. I'm not going to get into the insurance piece, but it can be very expensive. Falls can be very expensive. So what are some things that we can control, and what are some things that we can't control? What are some things that are intrinsic to us, and some things that are extrinsic that we can challenge and we can change in order to reduce our risk for falls? So what are some intrinsic fall factors, right? So we've got strength, we've got, you know, balance, right? So who here is on more than 4 medications? Okay, so we call that polypharmacy. So if you're on more than 4 medications, you always want to talk to your pharmacist, and especially in your primary care physician, and make sure that the combination of them isn't contributing to your risk for falls. Okay. Lack of sleep and mental status, to me, they go hand in hand. If you're tired, you're going to try to do things quicker. Okay. And then chronic disease, comorbidities, diabetes, which can lead to neuropathies, you know, and sensation changes, right? So this is meant to say extrinsic here. So loose rugs, right? So whenever I worked in homes or when I worked in home care, the first thing that I would ever do is take out all the loose rugs. And the irony is that at my clinics, I have rugs all over the place, and my staff, give me a hard time about it. But I just don't want there to be a ton of salt and stuff in the clinic. That's a whole other conversation for another day. But first thing I do is always get rid of like the fancy carpets with the thick ply. First things to go. Okay. Cords. Commonly when I was doing the home care assessments, I wouldn't see a ton of cords where people walk, but that's something to be considerate of. Poor lighting, right? So that's something I would always talk about, because the bathroom and the kitchen are the two most common to me. Bathroom, probably bedroom, and then kitchen are three really unforgiving places to have falls, but also three places where you really want to have them well lit up at night, so that if you do need to make a trip to the kitchen or to the bathroom, and for men as we age, our prostates tend to hypertrophy a little bit, get larger, and you end up going to the bathroom 2 or 3 times a night, and that's normal, right? But if you're getting up and you're already a little dizzy because maybe you have a little bit of vertigo, and vertigo is common, it's just little crystals that can get dislodged in your inner ears. You can be a little dizzy, get up, and we're not even talking about blood pressure, because you could have a little low blood pressure when you go from lying flat to standing up. That's also normal with aging. And you're not totally yourself as you walk into the bathroom. You want to make sure that that space is lit up. So just night lights is usually what I recommend. So the fear of falling. So 60% of folks over 75 years old express a fear of falling, okay? So while normal, I want to talk about what happens, the consequences of that fear, right? And not having a conversation with a provider about it. Or a loved one. So I always say the first fall begets other falls, right? Because you fall, then you're afraid to fall. So what do? You decrease your activity, right? You don't go to that yoga class. You don't go to that Tai Chi class. You don't go to the gym because you're afraid of falling, right? Less activity, decreased muscle strength and balance, because you're not using your muscles, you lose them, okay? That leads to an increased actual risk for falls, right? We'll talk about that. But when you have an increased actual risk for falls because you've decreased your activities, you're going to have more falls, right? So some of the testing that we do, and I'll get into that in a little bit, are things like standing on one foot and being able to balance for 5 seconds, right? So we know that if you can't stand on one foot and balance for 5 seconds, you're at risk for an injurious fall, a fall that could put you in the hospital. If you can't stand on one foot and balance for 10 seconds, you're at risk for a fall, right? So these are why, as physical therapists, we're taught in school to watch people walk, right, and analyze gait. So when I see somebody walking into the clinic and their base of support, their steps are here, I know the first thing, even before I address pain, and we'll talk about pain, is we're going to talk about a balance program, right? Really get that person to be confident with at least balancing on one leg for 5 seconds. Okay? Right, so these are all, the next couple slides are things that can increase your risk for falls, right? Common factors that you may have that could increase your personal risk for falls. So common indications for a higher fall risk, right? So feeling unsteady when you first get up, okay? That could be for any number of reasons. It could be from hypotension, right? So low blood pressure. It could be your medications aren't properly titrated, right? So it's really important, anybody here, especially on 4 or more medications, should always be, every time you go change those medications, follow up. The pharmacists now have doctorate degrees. Ask the pharmacists to review your medications and make sure that all of the prescriptions are correct and that there's no bad interactions in between the drugs. And also, if you're experiencing symptoms, don't be afraid to talk to your family members and your providers about them, okay? Whether you're lightheaded all the time, there are a million things that can contribute to it, but it could be a simple medication dosage issue, right? We're just not getting enough water, getting too much salt, diet issues, things like that. So that's one. So if you've had a fall in the past year, that increases your risk for falls, right? If you start using your hands to either push up off your knees or push up, you need to sit in a chair with, what do you call them? Arms chairs. That's the only chair you can now sit in. Increased risk for falls, right? Because what does that tell me? Weaker quads, okay? Furniture walking. You can only take a couple steps at a time without balancing on something else, okay? Increased risk for falls. We talked about standing on 1 foot for 5 seconds. Difficulty with flexibility, right? So just bending forward, touching your toes, right? Things like that, because what happens when something falls down, right? You have to go pick something up on the ground. If you don't have a reacher, you're gonna have to, I call it the golfer's pickup, but if you don't have the range of motion, your body's gonna do something to compensate somewhere to be able to pick up whatever you dropped, okay? Which could mean that a back strain, a hip strain, any of that. Who here ever gets dizziness? So lightheaded or spins? No one? Okay. So dizziness is often, there's 2 different types of dizziness, okay? There's the dizziness when you stand up and things start to get, like you kind of see stars or things start to get, you just get lightheaded. There's also the dizziness of the spins. The spins is vertigo. So I think we've had some hands, somebody's had vertigo in the past. Vertigo is typically when you get up out of bed or you roll in bed, you'll get some spins. So if you have any sort of dizziness, that's going to increase your risk for a fall. And again, vertigo is easily treated at a PT clinic. Difficulty negotiating curbs or steps, more difficulty reaching overhead, losing range of motion, right? So what do you do when you're trying to get that top mug out of the cabinet? You're reaching, right? Well, you could just get a step up, bring yourself up to it, and grab it. The one thing I don't talk about in this presentation is for shoulder pain and shoulder range of motion, your risk of just having a rotator cuff tear, right? There's 4 muscles in our rotator cuff. Your risk over the age of 60, almost 75% of people have a little rotator cuff tear just over the age of 60. Over the age of 70, it's almost 80% of us have a rotator cuff tear. Whether it's painful or not, we may not know, but it's going to make it harder to reach up above 120 degrees or so. Okay, so just keep that in mind. It's why it's so important to just do, make a partnership with a personal trainer or a physical therapist in your area that can teach you to stay ahead of these things, and that looks at the whole body. Other things are, decreased sensations. We talked about peripheral neuropathy, if you've got diabetes or lack of sensation in the feet. Footwear is a big thing, right? So wearing appropriate footwear. High heels if you've got balance issues, probably not the best solution. If you're taking, sleep medications, just be wary at nighttime. But my biggest thing, if nobody takes anything else out of this talk today, it's, if you've had a fall or you have a fear of falling, open up a dialogue with a provider, right? Because that fear of falling is what creates falls. Rushing to the toilet is another big one. That's a tough thing to solve because I know that feeling of incontinence isn't wonderful. There are ways to solve it. You can put if it's a really high risk for falls, you can put a commode next to the bed. It's not my favorite solution, but just make sure that the pathway to the bathroom is lit up and that when you sit up at night, just take 10 seconds to collect yourself, okay? So sit up, take 10 seconds to 20 seconds to collect yourself, and then if you have an assistive device or a cane, make sure that's close because you're taking that to the bathroom as well. So if you guys were thinking about that in the back of your heads, I rattled through about 12 different things. So if you answered yes in the back of your head to 3 of those things, then you've got a risk for falls. What can you do? We just talked about medication management. That's a big one. Opening up a dialogue with a provider, right? So the first, if you've got a relationship with a physical therapist, talking about it, talking to your primary care about it, and then I would even say, your optometrist, right? Because vision is a huge component of balance. So if your visual acuity is not great, make sure you got the right prescription and you've got a good relationship with an optometrist. The second thing is just exercising. So who here exercises 3 days a week? Michelle, do you guys still do exercise classes?
Yeah, lots of them.
Yeah.
Tai Chi, muscular strength, chair yoga, mat yoga.
Great, awesome.
Cardio.
So my advice, so of all those classes, so Tai Chi is clinically proven to improve balance, okay? Tai Chi is one of the best things you can do in my research, just to improve longevity of life, right? For a number of reasons, but decreasing blood pressure, right? Improving your balance, your brain, right? 3 times a week, right? So of all those classes, if you can exercise 3 times a week and be consistent about that, then you're doing what you can do to prevent falls, okay? If you can do 5 or 6 times a week, even better, but I would definitely say choose something that you love and be consistent with it, okay? Consistency is what helps. It's the longevity of it. You can't just do something for 2 months and then think that it's going to help prevent falls. We want to be consistent with our approach to exercise. PTs can help you develop a personalized program. You know, a common question that I get as a physical therapist is, do I need pain to come see you as a PT? And it's a common thought that you need to be in pain, but if you have a fear of falling or you feel as though you're not steady on your feet, the first person to have a conversation with that or about that with is a physical therapist. It's really important. The second most common question that I get is, do I need a doctor's referral, right? And what I always say is, make sure that you check in with your primary care. Call your doctor's office, and 9 times out of 10, they send whoever you want to go to, they just send them a referral. They fax it. So it's a very easy process, but you have to start the dialogue, right? Typically, when a provider is starting that dialogue, it's after a fall, right? And we don't want that. The third easiest thing to do to prevent falls is just getting rid of those throw rugs, making sure the line of sight to the bathroom, to the kitchen is clear. And just make sure you keep things that you use all the time within easy reach. You don't want to be reaching up out of the cupboard for your favorite cup every time you're trying to get something in the kitchen, or for the sugar or the flour. Keep it at eyesight or arm's level. Footwear is huge, right? So, flip-flops, things like that, just not the best, okay? So especially on tile floor, or, God forbid there's a spill in the kitchen or in the bathroom, there's a little water on the floor, and you're wearing, inappropriate footwear, or, footwear that's flat on the bottom, you could have a fall on the top. Don't wear stockings when you're walking around. That's going to decrease the friction coefficient. And then just wear shoes that fit well, right? You can be fit for shoes. There used to be a store in Sutton that I liked. That was kind of a small mom and pop for footwear. It was next to the post office. I use a guy now in Worcester. He's called Sneakerama. He's on Shrewsbury Street. Steve Genetasio, I think is his name. He does a good job. He goes a little above and beyond, and he's a small business, and he'll get you what's right for you. And then just work with your PT, to identify, what's actually causing your personal risk for falls. Is it vision? Is it your sensation, right? Is it your strength? Is it your range of motion, right? So again, and even posture, right? So how many of us start to lean forward, right? Or you're curled like this, or your neck is here, right? You're staring at a computer, you're staring at TV, you're reading a book. Right? Everything that we do in life is in front of us. It rounds our posture. 90% of the exercise programs that we prescribe as physical therapists in general, not just at Concierge, are for the muscles in the back, right? So I always say do 3 back exercises for every 1 pushing exercise. And that's just for anybody. But that's definitely what we do when somebody's in treatment for any sort of upper extremity pain. Also, think about what bad posture does to your center of balance, right? It brings it forward. And then you're leaning backwards to try to regain your plumb line, and that can contribute to falls. You want to really make sure that you're doing what you can for balance. and for posture. We have tests that we do to assess your risk for falls, okay? Some other things that we do to test, in a battery of tests for your risk for falls, a 5-time sit-to-stand test, right? How quickly can you stand up and sit down without using your hands 5 times, right? So that number should be less than 10 seconds, okay? And what I often see is people trying to go too quick and then they fall back, right? Another thing that we do, how quickly can you get up from a chair, walk 10 feet, come back to the chair, okay? A timed up and go test, okay? So those are 2 other common tests that may be done to you or may have been done with you if you've ever been to PT, that just test your risk for falls, okay? And what do, right? So if those are directly correlated, those tests are directly correlated to your risk for falls, I'm just testing your strength and your gait velocity, right? And your safety during that. So those are 2 things that we can work on as physical therapists. And so again, early intervention is it's opening the dialogue. If you feel like your balance is off, or you feel like you're getting weaker, or you feel like you're not as active as you used to be, those are all things that contribute to your risk for falls. This says contact your rehab department. I've been doing this talk for a long time, so. Just what I would say is I would contact, your local physical therapist, talk to your primary care about it, and ask what can be done. Okay? Questions? Silence.
Oh, I have a question.
Mary.
Seriously, because I really do know that I've noticed with myself that I am dependent on my eyes so much. What things can you do to not, like you said, with the shutting of the eyes? So doing something like that and practicing standing on one foot is a good idea for strengthening?
So great question, right? So I think, did everybody hear Mary's question, or Mary's
Concern.
Yeah. So she said, how can I challenge my vision,
Yes.
from what I'm hearing, to help my balance? So great question. So yes, so that is one of the things that we do in the PT clinic, is we use some sort of combination of the vestibular testing, the sensory testing, and the vision to be able to put together like a custom program for what you're looking for. So if you had difficulty with closing your eyes or taking your vision completely, do you wear glasses?
No, I don't.
So it's not an acuity issue, right? So the first thing I would say is we take out an eye chart and make sure that the vision is, where it needs to be, right? So the second thing that I would do is I'd go into a variety of different standing positions, right? So I'd rule out that it's somatosensory, right? So if you're having issue with a tandem stance or a single leg stance, that's the next thing I would do. I would get to the hardest version of that, and then I would add your vision, right? So I'd say, close your eyes, right? And so sometimes what we have to do in the clinics is put a foam underneath your feet, right? So we change the foam, okay? We can use a Bosu ball. We can use discs, little discs that you can stand on to challenge you. So it's not always single leg stance. You could be just standing on a blue foam. You could be standing like this on a blue foam. So there's just a variety of different ways that we can challenge you. You can be standing like this with your eyes closed and turning your head left and right? That can improve. So to answer your question, what are those techniques, right? So those are adaptation techniques, right? So we're giving you different tools to be able to kind of like account for what happens when you close your eyes, right? Does that make sense?
Yes.
Yeah.
The other question I have, because I do yoga and a cardio. Yoga, I'm not wearing shoes.
Right.
Cardio, I am.
Sure.
Which is best, to not wear shoes or?
Yeah, I mean, so for yoga, I think it's standard not to wear shoes. I think
Yeah,
that's,
no,
that's
I know
good.
that, but I mean for practicing.
For practicing your balance.
Yes.
I would say, if you're otherwise healthy and have no risk for falls, I would do it without shoes on.
Okay.
If you have a history of, plantar fasciitis or foot pain, wear something supportive, right? Wear something supportive that's going to decrease your risk for, it's harder to balance with your shoes off because there's micro accommodations that happen at the metatarsal level and at your midfoot and hindfoot that happen first before the highest level of our professional athletes. The first thing they use to balance is their ankle, their feet. As they start to get, let's say professional basketball player, Jason Tatum, he sprains his ankle, right? Or Mac Jones, so he has a high ankle sprain right now. He's using his hip and his knee to balance because his proprioception at his ankle is terrible because he's got swelling there. So he's accommodating with his hips and his knees. So back to your question about, feet, footwear or non-footwear. That's a question. If you have a relationship with a PT, I would ask the provider first. But if you haven't had any history of falls, I would do it without socks on or shoes on. Because that's where you're going to get the most brain-body connection.
Okay.
Yeah. And that's why I think they do it in yoga. Yeah.
I've had non-diabetic neuropathy for 30 years or so.
Yeah.
And it's at the point I can barely feel my feet. I mean, a doctor goes like this and nothing happens,
Right.
So I have a lot of nerve damage.
Sure.
And I try to put in a mile a day at least, walking, even in the house, back and forth.
Great.
But my balance naturally is, with no feeling in my feet, is off. I can't drive even because I can't feel the pedals.
Right.
So what do you recommend for somebody like me that's, a lost cause? There's not much I can't stand on one foot, I can't balance too well,
Yeah.
so.
Yeah, so my answer to that is the first thing is the philosophy change, right? Because you're not a lost cause.
Oh, I know that.
Right. But you say that.
That's why I walk a mile a day. And I
so,
come
but
to chair yoga.
But that philosophy of, I have peripheral neuropathy, there's nothing I can do about it. Some people have painful, really
I do.
pain too.
Yeah.
Some people, it
My
keeps them up at night,
fingers.
right? So, and there's not much as providers, there's Lordan or gabapentin,
That's what I
right?
take. Yeah.
There's capsation treatments that are kind of like hit or miss. There's not really much that we can do, right?
Yeah,
So
I've
I've
had
got,
everything, so.
yeah, and I've got a fancy machine at my Shrewsbury clinic called Shockwave or, EPAT. And, I've talked to local physicians and providers and physiatrists about maybe doing a case study with that for neuropathy. But to your point, there's not much you can do about peripheral neuropathy, right? So
Yeah.
there's a decrease, feeling back to you can't feel, right? So what do you do to work around that? And back to Mary's point, what we do is we do, if you're not strong there, you better have a strong visual and vestibular system, right? So
Yeah.
if you're weak in one of the three, I call it a pie chart. So if your pie chart of sensation is there and it's fixed, we need to make sure that your vision
Yeah, that's fine.
and your vestibular system are accounting for are really strong, right? So my advice, right? So walking is great, right? And so make sure that if you can't feel, you always wear footwear, right? Because
Oh,
if you
yeah, I can't go
feel,
barefoot.
right, you could step on a tack and
And
not
not
feel
know
it, and then it's an ulcer, because you're not checking that all the time, right? And that goes back to decreased range of motion and different things like that. Make sure that the surfaces that you're walking on are as flat as possible, right? Because if you can't feel, you need stronger ankles and you need good strength in your anterior tib group, so you're making sure that you're catching
Yeah.
you're lifting up your feet when you walk.
Oh, I do that.
So just what I would say is I'd start with a strengthening program to make sure that the muscles around the foot and ankle are strong, your anterior tib is strong. One of the best exercises you can do as you age, just to even improve your gait, is calf raises, okay? And then anterior tib, just bring those toes up like this, okay? So standing tall, not bringing your butt
I have to
back.
hold on to do something like that.
Yeah, and you could even do it in sitting. So I just saw you doing it here, just lifting up. I would do the calf raises against gravity. So your calf strength is directly correlate to your ability to walk with speed, right? So the weaker your calves get, either from you could have a herniated disc or a bad back, all those, the discs in your spine connect to those muscles in your lower body, right? So has anybody here known anybody with foot drop?
Oh, yeah. I
Yeah.
know
Right.
that.
So that could be from peripheral cause, or it could be from just injuring your low back, right? So, and that's why it's good to have a good relationship with a provider or a physical therapist in your area, so that they can look at your whole body and figure out that it's that your low back isn't causing any neuropathic symptoms in your legs, right? But that's a separate conversation for another day.
Yeah, because I also get sciatica.
Right. So those are two separate problems.
Yeah.
But again, it's
But kind of related, he said.
yeah, and as we get older, it gets more difficult. Some providers just hone in on one thing,
Yeah.
right? So it's so important to know somebody who can look at your whole body and who can understand that one thing can lead to another. Everything really to me starts at that pelvic girdle, and at your core. And, things that we look at are flexibility, strength, quad strength too is tied directly to mortality and morbidity rates. The weaker you are in your quads and your glutes, the higher risk for mortality. So just things that it's important to start a solid exercise program
Yeah, well,
and do it at least 3 days a week. And I love the mile walking. I think that's great.
yeah, I mean, I get it on my phone, carry my phone in my pocket so I can make sure I get my mile in.
And
At
so
the end
what,
of the day, I'm running back and forth. Like I'm in the kitchen.
Making it up.
Yeah.
and what's your first name again?
Mary Alice,
Mary Alice.
yeah.
So one thing that Mary Alice does well too is that she has a number, right? So her number is 1 mile. Everybody in this room should have a number, okay? Either it's related to your health or whatever your goal is in life. Create a number from it, or what we call it, gamifying or make it a game, right? So her game is I got to walk a mile every day, right? So Mary Alice's game is a mile. My game, personally, is I want to get to the gym 4 days a week, right? So with two clinics and 2 little kids at home, that's not an easy feat. But that's my number, is 4 times a week. So think about that. If you guys take nothing else from this talk, 2 things that I want you to be aware of. The ability to balance on 1 foot for 10 seconds, okay, is directly correlate to your risk for falls. I think that's the most accurate one. And the other thing is just find a number, think about a number, tie it to your health, and try to be true to at least 3 days a week of exercising, whether it's chair yoga or Tai Chi or an exercise program. All of that's great. Just move, okay? Anything else?
Yeah. Oh, is there a question? No, John, go ahead.
John?
No, just your, the comment of standing on 1 foot for 10 seconds, and I noticed Mary, when she closed her eyes, couldn't do it.
Right.
Do you think it would be helpful to just practice that? Trying to close your eyes and stand on your foot, just practice that for a while, because it's something you can do by yourself at home and
I'm-
anytime.
You could
Yeah,
hold,
100%.
you have to be something you can hold on.
So, and again, I think that it's John.
John.
Yes. So that,
John and Mary.
John and Mary, perfect. So what John asks is it easy enough just to practice it, if you feel as though you can't do the task, practice the task. I think that's great. You're just training to that task, right? So you're not hitting the myriad of other things. But I think it's an intelligent thing to do. So what you're doing is you're training your vestibular system and your somatosensory system when you're doing that. And it's all the way I think of it, John, is like a pie chart in my brain, right? So you have your sensation, your vestibular system, and then your vision, right? So if we take vision out of it, what are you training? You're training your vestibular system and your sensation. So whatever you're weakest in is what we want to either make that stronger if we can, or we want to make the other. In your case, your sensation is fixed, right? So you have a decrease in sensation. So what we need to do is accommodate. So her program is going to be accommodative, and we're going to make sure that her vestibular system, and her visual system, we work them so they can bring them up to par. Every balance program is a little bit unique and a little bit different, depending on tailored to your past medical history and your needs. There are some general balance programs out there that I think are good, but another, balance is directly correlated to strength too, right? So sit to stands, great exercise. I love the sit to stand because what that does, it trains almost every muscle in your body, right? If you do it right, because you can get all the way up to the core. It's essentially just a squat. But the first muscles to atrophy on men as we age are your glutes, right? And your glutes are your extensor muscles. So all it is you're just kind of giving into gravity as you age. So you start to lean forward, your glutes start to atrophy. And the sit to stand or the squat is one of the easiest exercises to do, to ameliorate that and to kind of push off the balance conversation a little bit later.
I haven't got the strength in my legs to do that.
Right, so if you can't do the sit to stand.
Yeah, I have like a tub surround that's a little higher, and I do it off that, but I can't get out of this without holding on.
Right, so Mary Alice just said she has difficulty with sitting to standing from, especially a chair without arms, right?
Yeah,
So,
well, yeah.
and
No,
so what I say-
can hold on here and get up, but I can't,
so what we do at the clinic is, we put pillows down, or I put foam down and build up the seat,
That's
right?
what
So,
I have, yeah.
so you're still training the same muscle groups, you're just making it a little bit easier,
Okay.
right? So you want to do the activity because it's a functional activity. You have to be able to do it to get out of bed, to get out of
Yeah,
chairs,
yeah.
to get in and out of the car, right? To be independent. So it's really another exercise that's tied to independence, right? It's just, if you can, I'd hold a weight while you're doing it too if you can, but that's also my strength side. So don't be afraid. There have been studies that have shown male and female into their 90s are able to not just maintain strength, but to build strength, hypertrophy muscle tissue, strengthen it, build muscles. So just don't be afraid to add resistance or add, and if you're afraid, talk to a personal trainer, talk to a PT. If there are clerical issues or something like that, just your doctor's office can walk you through them. Michelle, you had a question?
I think you pretty much answered it. We have several older folks that I think this is very important for. But I also know that they're not gonna get out and do that exercise 3 days a week or whatnot. I think it's really about tailoring a program that's for seniors that are 80 and above, that are really kind of resistant to doing that. So changing the mindset is really kind of the thing.
That's
Pretty much
difficult.
answered that.
Yeah, and so this past weekend I was actually, I was in Denver at a conference, a PT conference, and one of the big pushes as a profession that we're trying to do is remote therapeutic monitoring, right? So what that means is monitoring, especially, and it's actually a program that's already rolled out with Medicare patients, and what it is basically we see you in the clinic, but then you're also responsible for the home exercise portion, right? So you're logging into a platform, you're looking at the exercises, there are my directions going through them, and it sort of holds you accountable. You have to check off that I do these exercises every day, and it's an interactive strategy. It shows videos of how to do the exercises because half the time you forget how to do the exercises. So that's where the profession is going. Right now, I still print out home exercise programs and hand them to people, or I email them. The remote therapeutic monitoring is something that we're actually, as a business, looking into incorporating as a solution to help, just the accountability piece, because it's more interactive. It's not, hey, Mary Alice, did you do your home exercise program this week? It's, yeah, of course I did, Sean. Yeah, but when I can see that you logged in and you checked off that you did the sit-to-stands, the long arc quads, the marching, it's just there's an extra added layer of accountability to that. But again, I would just say, if you're even thinking about, you have risk for falls, just begin a conversation with a provider near you that can help you. So yeah. Hi.
Hi, I came to Concierge last fall because I had hip pain.
Yeah.
And I had Megan, and I loved her. She was wonderful.
Yeah.
And everything she did make me feel better that day. But, it's something you have to keep coming back to. And eventually, I had the visiting nurses who actually were having me do the similar things.
Yeah.
And I still have the paper on the fridge with stick figures in. So I try to do some of those, but you do get discouraged. How much do I have to do this every day? Because I can fill my day every minute with other stuff. And so I've had the surgery, and that was great. Now I have the knee. I thought I could get rid of this, but now it's another issue.
Yeah.
And I'm not about to have surgery on that.
Yeah.
So I'm trying yoga. I used to go to the gym 3 times, but now that's too much for me to get there.
Sure.
And plus, it'd be every single day I would be out. I could be here every day. But
Instead of
how
3
much
times
can
a
you
week.
really do?
And what's your first name again?
Sorry.
Your first name again, I'm sorry.
Marge.
Marge. So Marge. So Megan's great, and she's one of our, so Megan is, she's got 15, 20 years of experience. She's a great provider. And she's an asset to my company. But I think this just ties back to, your plan of care, right? So what we talk about in PT is, so if I see you, I say, okay, it's going to be 3 times a week for 2 weeks, twice a week after that for another 4, and then it's gonna be, okay, we check in once a week or once a month or however we check in. You shouldn't be, a physical therapy lifer, so to speak, right? But certain aspects of what we do should be done every day and every week, right? So, I always go back and forth, because I feel as though, and there's actually been litigation about this with folks with degenerative disease like Parkinson's, that Medicare will cut them off, right? So they'll say, hey, listen, no more PT. There's no cap for Medicare with PT services anymore, because they were sued because they cut somebody off and they declined and passed away, right? So now, as long as it's medically justified, you can continue PT. But to your point, there should be sort of a plan around that, whether it's 10 weeks or 12 weeks. There should be some sort of grand plan with the intent that you're independent and that you're able to do, the yoga, the tai chi, the home exercise. And that last week or 2 of visits should be talking about what your plan is post-PT and what that looks like. And we're always here. We're always going to be the backdrop. You can always pick up the phone and call. And if there is pain, I always say pain is an indicator to call, to call a PT, because that's an immediate concern. But the plan of care is important, and knowing to ask about that. Not many people know to ask, or they're afraid to ask. Hey, how long is this supposed to take? Is this supposed to take 10 weeks? Is this supposed to take 3 weeks? I feel better. And a seasoned physical therapist will be able to tell you, hey, let's say it's low back pain and you're 60 years old. Low back pain at 60 is just different than low back pain at 25, right? It's going to take you 6 weeks just to even kind of get to a plateau, and then we're going to start having a discussion, right? But if you're not doing what we want you to do in those first 6 weeks, you could be crippled. The low back is one of those funny, not funny diagnoses, but it's very difficult to treat low back pain. And I think any provider, chiropractor, or anybody else will tell you how difficult low back pain is to treat. But back to your point, having a strong plan of care, knowing to ask, hey Megan, how long am I supposed to be here for? Right? Is it 8 weeks? Is it 10 weeks? Is it 3 months? Is it 6 months? Is it just a couple days? Is it a check-in? That's really important. And then Megan, and that's why I love for my providers to check in. Have you gotten a call from Megan since you last saw her?
No.
Okay.
Have I had a call?
Yeah, has she called you just to check in and see how you're doing?
She did before I had the surgery.
If total joints aren't an option, right, that can get difficult to manage chronic pain. That could be a talk for another day. I could probably talk for an hour on that, but that's, and again, that's why you want to kind of be able to find the right provider for you. And if we can't fix it, then we know who can, right? Whether that's physiatry, chiropractic, orthopedic surgery. There's a web of different providers that, when you're in the medical world and you're a practitioner, you just have more of a sense of, where those referrals need to go. So that's, maybe something we can talk about after. Okay, awesome. Well, thank you everybody for coming out. Really appreciate it. It was a great turnout.